And Stuart Grant, can we? I think yours is.
So Stuart's going to present. We wanted to just get some examples of the different kind of things we could do with the database research-wise, and we've just picked two examples. So Stuart's going to present some stuff we've been doing looking at mitral prosthesis choice and outcome.
Okay, thank you, the panel, ladies and gentlemen. So this is an example of a research project and the type of thing that can be done using the SCTS database. And we looked at mitral valve prosthesis choice in patients aged over 65. So the background to the project is that the American guidelines recommend insertion of a bioprosthesis for patients undergoing mitral valve replacement aged over 65. The European guidelines are a little bit more vague and have this grey area between 65 and 70, but they generally recommend that mechanical valve should be implanted for patients under the age of 65 and a bioprosthesis for patients over the age of 70. However, the guidelines are generally based on limited evidence and tend to be consensus opinions. So the objective of this study was to examine whether the guidelines are being followed in UK practice for patients aged over 65 and to investigate whether the guidelines are in fact appropriate based on both short-term and mid-term mortality data. So to conduct the project, we looked at all SCTS records over a 10-year period from April 2001 to March 2011. The data was cleaned and validated using the standard methodology that we use for these projects, which is available online. We looked at all mitral valve replacements, plus or minus coronary artery bypass graft surgery, plus or minus tricuspid repair, and excluded all other procedures. We also excluded emergency and salvage cases, so this was just elective and urgent patients only. With regards to the analysis, we imputed missing data using a single imputation approach. We then developed a propensity score using logistic regression analysis. We used this propensity score to match patients using a nearest neighbour method on a one-to-one basis, and we initially compared outcomes for the primary analysis in the matched cohort patient data, but as a sensitivity analysis we conducted logistic regression and Cox proportional hazards analyses on the entire data set. So the data included 4,061 patients over the study period. I'm pleased to report the missing data was very minimal for all but 3 variables. It was less than 5%, and the remaining 3 variables were not really much more than that, at about 6 and 7%. Interestingly, just over half of the patients had bioprosthesis. 11.6% of patients had concomitant tricuspid valve repair, and just over a third of patients had mitral valve replacement plus coronary artery surgery. So this slide shows the activity over time, and interestingly, the proportion of mechanical valves implanted in these patients is decreasing. This slide shows a within the age group breakdown into different age groups, and as you can see, that the older the patients are over 65, the less likely they are to have a mechanical valve inserted, but we still have some patients aged over 85 who are having a mechanical valve inserted. This slide breaks it down by hospital, and so the number of mitral valve replacements performed during the study period is along the x-axis, with the bioprosthesis implantation rate on the y-axis. And you can see the significant variation in the rates, with some hospitals inserting over 80% bioprostheses and some hospitals inserting less than 10%. And there's no real correlation between outcome, between volume, and the bioprosthesis implantation rate. As would be expected, if patients in atrial fibrillation, they're more likely to receive a mechanical valve, and this was statistically significant. So we then went on to matching after analysing the whole data, and we matched 1,245 mechanical replacements to 1,245 biological replacements. The histogram on the left of the slide shows the data before matching, and it shows there's a significant difference in the propensity scores. The histogram on the right of the slide shows that following matching, we actually had quite a good balance between the groups, and no variables differed significantly when we looked at the standardized difference between them. These results are in the matched cohort. The overall mortality was 6.5%, and there was no statistically significant difference between for in-hospital mortality between patients who received a biological or mechanical valve, with an odds ratio of 1.09. This shows the sensitivity analysis in the full cohort, adjusted for other risk factors. And again, the odds ratio for the for prosthesis type was not significant, with a p-value of 0.237. We then move on to the survival component of the analysis. The median follow-up for the study period was 3.9 years. And when we look at the Kaplan-Meier curve, they were strikingly similar. So log-rank test was not significant, with a p-value of 0.64 and a hazard ratio of 1.03. When we move on to the sensitivity analysis of the full data, the hazard ratio was in fact 1, with a clearly insignificant p-value of 0.945. So to conclude, with regards to the general trends, there's been a decrease in mechanical valve usage over time in this patient age group over 65. Practice is variable at different centres, and as far as the guidelines go, these aren't being followed, at least in UK practice. However, from this data, we found that it doesn't really matter, as there's no difference in either in-hospital mortality or mid-term survival between the groups. As part of this analysis, we've not been able to look at, obviously, at patient preference or other factors that may influence valve prosthesis choice, but as far as our results go, these are the conclusions.
Thank you very much. Are there any questions, please, on that paper? There's one at the back. Thank you.
Excellent paper. Thank you very much. I enjoyed it very much. Just one comment, really. I think the data is great and all that is excellent, but I think it's difficult to conclude that it doesn't matter that we're not following the guidelines, because the follow-up is essentially only for 3.9 years. And the difference in survival or reintervention or anticoagulation-related problems between the two groups is going to become apparent only in the later age groups and in the years to come. So I think it's difficult to conclude that it doesn't really matter that we don't follow the guidelines, because the results at 4 years are about the same. And that's the only comment I'd like to make.
Yeah, we are planning to look at these. It'll be difficult for us to look at bleeding complications in a long-term follow-up, but reintervention is certainly one thing that we're intending to look at as part of this project going forward.
Thank you. Any more questions? In the interest of time, we'll move on to the next speaker, which Professor Bridgewater is going to introduce.
The next talk, again, was a submitted abstract from Graham Hickey, and it seemed to fit in this session. So Graham's going to talk about the use of other approaches in terms of dynamic modelling. Thank you.
Okay, thank you very much. I'd like to thank all my co-authors on this, and again, Heart Research UK, for funding this research. So I'm going to discuss dynamic clinical prediction models, in particular in cardiac surgery. So the history of cardiac surgery models, prediction models that is quite well known. If we go back to the Parsonet score, and then we move shortly afterwards, 10 years, onto the additive Euroscore, and then eventually onto the Logistic Euroscore, which became dominant, especially in Europe, for a good 10 years. The SCTS have published models, in particular procedure-specific and also for different outcomes. And then in 2012, we were welcomed with Euroscore 2, which was a far superior model to the Logistic Euroscore. But then the question is, where next? So the obvious question is, well, let's try and understand what went wrong with Logistic Euroscore. And what we have here on the left-hand side, the black curve that's going down, is the observed mortality in England and Wales for 2001 to 2011. And what we see is that it has been slowly going down. On the other hand, the predicted mortality, if you would call it that, according to the Logistic Euroscore, has been going up, representing the fact that patients coming to surgery currently are becoming more and more risky. They're having more and more complex surgery. And so the observed to expected ratio, which is shown on the right, has been decreasing significantly over time. And by the end of April 2010, I think that should be 2011 actually, the predicted mortality was 2.7 times the observed mortality rates in the England and Wales. So what would happen if we just used that? If we were to, for instance, do a governance analysis with it, and I alluded to this point before, well, this would be the funnel plot we would get. We would find that all surgeons look like they're performing well above, or rather well below the mean mortality, so above standard, and there are no outliers. But that's clearly false, so it is a misrepresentation. So what are our options? Well, we could do nothing. For instance, we could just develop a model, and we could just leave it to run forever, and we could never go back to it. Alternatively, we could periodically refit the model. So, for example, every 1 year, we could take our model and we could refit it to contemporary data and update our model coefficients, for instance, update our online calculator to calculate the risk score. An alternative option would be to use a rolling window effect, perhaps for stability. So you can imagine that we would have, for example, a 2-year window, but we would shunt that 2-year window, or we would roll it on, for instance, every 1 year or every 1 month. And for that roll that we just made, we would update the coefficients for that time period. Finally, the alternative option that we have is to use what's known as dynamic logistic regression. So the idea is that we formally model the temporal elements of the regression model here. And in some sense, we discretize time still, in my case, 1 month. But what it means is every 1 month, the model coefficients will change, and they should change smoothly. So to give you a bit of an idea of the nuts and bolts, and I won't go into this in any detail, it was this logistic regression model was proposed in a biometrics paper by a Professor McCormick, who's an American statistician, and he published this along with some software. And the idea is that it assumes the so-called state space equation, which essentially, these betas are your model coefficients in your, say, your logistic regression model, and it relates the coefficients at any point in time to where they just have been, say, the previous month. And we apply some what's known as Bayesian statistics to that. We put a whole host of assumptions and approximations, and you work through all the calculus, and eventually out comes an answer. So for this study, what we did, we focused solely on the Euroscore risk factors, because those are the ones that database managers in this country really strive to make sure that we have very little missing data on. We trained all the models on either the first year or first 2 years worth of data, and then we updated them continuously according to their protocols, and we just we monitored the model coefficients. So this will be clearer with the results. So to put it into perspective, for this analysis, we had over 310,000 records to deal with. We had 37 different hospitals contributing, and we had 10 years worth of data. So here are some of the results, and I'm clearly not going to be able to have time to go through them all, but there's some interesting conclusions that come out. So the models are described by the different colored lines, and their definitions are given on the legend just below. So the red lines that go horizontal is the idea that we do nothing. You can imagine if I built Euroscore in 2001 with those variables and let it run forever, that would be my model coefficients. But what you see is that over time, if I use any of the alternative approaches that dynamically adjust for the changing associations that have occurred, you see that risk is changing. So for instance, the risk associated with previous cardiac surgery, which is, I don't have a pen, the risk associated with previous cardiac surgery has been increasing. So from, these are the log odds ratios, because it's the coefficients in the logistic regression model. It's been going up quite substantially. Same with gender. On the other hand, pulmonary disease and neurological dysfunction, the association of in-hospital mortality with those risk factors has been decreasing at the same time. So it does lead an interesting pattern. There are some more noticeable ones. For instance, LV function, that has decreased somewhat. If you have a poor LV function, which is described as less than 30% ejection fraction, That association has changed somewhat. However, some risk factors have stayed quite stable, so critical pre-op, with the exception of the last year, that variable hasn't really changed in its association over time. What you notice with some of these different models that I'm presenting, and if you look at the recent MI, which is defined as within 90 days, that if I was to use an approach such as piecewise recalibration, so every 1 year I just take my model and I re-update it with my latest 1 year's worth of data, you see that the change in coefficients can be as much as double, or rather halved in this case. So from about 2006 going on to 2007, the financial year thresholds, there was this huge abrupt change. Now that's quite unfair if you're going to do a governance analysis for the person who did it 1 day before the financial calendar to the guy who did it 1 day after the financial year. So what we really do want is a smooth method for dynamically adjusting for the association. And what we see is that the dynamic logistic regression model is in particular one good case. There are other options for dealing with this, and we have explored some other methods. You might be wondering what has been the biggest change overall. Well, it's been the intercept parameter. So the baseline risk, when you don't factor in actually any of the risk factors, it's just been the overall observed mortality has been decreasing external to those factors. So I can't explain why that is. Perhaps just generally surgery is getting better for whatever reason. But you see that if we did nothing, that the red line, which is just my status quo approach, and I continued to use that for 10 years, I would be making very bad decisions if I was to use this as a decision tool. So in conclusion, doing nothing is not an option. A patient 10 years ago does not have the same risk for cardiac surgery that they do today. And in fact, a patient 1 year ago does not have the same risk for cardiac surgery as they do today. So what I would put to the audience is it sensible to wait for Euroscore 3 or some other risk model to come out? Because if you look at the last lag of 10 years, it's perhaps not feasible to wait. And whilst dynamic regression is methodologically complex, it's possible, but it would require a concerted effort to implement. This would have to be done by somebody such as the SCTS, or in America, the STS, because it would require computer infrastructure, it would require analysts, constant inflow of data and validation. We are close to having that infrastructure ready, but it would, of course, incur a cost. So that's it. Thank you very much.
Any questions for Graham on that? Just whilst the microphone's going down there, one of the things I think this is important is the right thing to do, I think, for the surgical community is to give you an idea about how performance will be next year, because at the moment we're always looking back on things, which isn't ideal. And one of the reasons why we started to explore this is because you can see conceptually when you've got these curves going through, you know where things have been, you can make some predictions about where they're going to give a more prospective view about what likely performance will be next year. And that's one of the reasons why we tried to explore this. But one of the difficulties we've got is that people have always been saying these risk models, you know, give us something better, but make it simple. And there's a difficulty there because you can have things which are straightforward and we all understand, or you can have things which maybe have some benefits but are more complicated, and that's a balance that needs to be struck here.
Andy Forsyth from here in Brighton. Having been in the game now for 40 years or so, I think it's a shame we've taken away risk measurements from, say, when we started 40 years ago. What you said was that one of the reasons it's all looking rosier is that surgery's getting better. Well, I can tell you that over the last 40 years, you're absolutely right. But if you use the same thing to measure cases from 40 years ago, the same risk measurement, and still use that, it will have gone up. So what we're doing is doing harder and harder cases according to that one measurement that was brought out 40 years ago. And the mortality or any other endpoint you want to measure is probably going down and down. And from those two things, even the public can see that we're getting better at our job. If you keep... So that's got nothing to do with the assessment on tomorrow's case, unless, of course, you put in what you're describing as a sort of fudge factor, because the patient wants to know, and that's easy to do. But the general public can always see that the results are getting better with increasing risk, and that's very important for us to have across any newspaper. The thing about just doing risk assessment on tomorrow's case is that the end result, as I think Ben showed or James showed on his case, is that it goes up and down. So if it goes up and down, then the public's going to say, well, if your mortality's gone up, you're no good, and you need to change something. We can't accept that. In the light of, you know, half of us here who do surgery are below par or below average. That's by definition. So I keep harping on about this, about using the same measuring stick. It's a bit like running 100 metres. If you're getting faster and faster, we change the length of the metre a bit and the times stay the same. But I must say, as a general comment over watching this for 40 years, I think that the work that Ben and James and people have done I don't think people in this room really understand how fantastic that is, and I'm very grateful. Thank you.
Thank you very much for the comments. I can't see with the lights, but...
Norm Bruffer.
Oh, sorry, I couldn't see Norman.
Norm Bruffer, Sheffield. Good talk, and interesting. The great problem, obviously, with all risk prediction models, whether it's Parsonett or this dynamic model you've just described, is the unknown unknowns. And it's interesting you pointed out that LV function is rapidly becoming less of a risk factor. And there's probably a reason for that, and reasons are tablets. And there are lots of things that we don't measure that we still don't know are leading to improvements in the outcomes of cardiac surgery. You know, the presence or absence of TOE, advances in heart failure clinics, and all sorts of things that we